Talk about your decision to treat patients using MAT. I know you have had your hands in that, as Dr. Owensby has. Um, the successes, the challenges, patients who have returned to use, even though they have been working with MAT. How do you manage those? So let's talk first about, your experience with using MAT.
I said I would never do it. So here we are again with me telling myself what I won't do.
Yeah.
hmm
I had that
So
conversation with you years ago. I remember that too.
I'm like, let's do the old school rehab way. But it's that does not work 100% all the time. The
Sure.
inpatient. So they were offering a free 28-hour or 24-hour
Mhm.
MAT waiver. I said, you know what? To build myself as a practitioner, do it. Go ahead and do it. My supervising at that time had been asking me for an entire year, and I was choosing to not. But then there was some drug reps coming around that also were pushing the waiver because, of course, that can also help their medications. And I said, I'm just going to do it because everybody keeps asking me. So I'm just going to do it. I did it. And it was one of the best things I've ever done, to be honest. Once again, my path is ordered.
Talk more about
Watching
that.
watching the recovery, watching their lives change has been a huge thing for me because I initially, like I said, did not believe in that medication in particular. So I did the training, got into the management of, and as you mentioned, there have been some relapses with many of the patients, especially when they're starting out, which is
Mm.
why my protocol includes giving them a chance to adjust to the new lifestyle that they're seeking after. In those relapses, though, when a patient has a relapse, I try to not be too hard on them, although I am at the same time. It's like tough love.
Yeah.
I speak to them from a very real standpoint. I sometimes get some excuses of the lab did that to my urine, or someone in the lab must be using drugs and now it's in my urine, or just certain excuses that I get. And I said, we're going to stop the excuses and we're just going to talk real here. You did that lab in that cup, not Tiffanie, not the lab. That is your responsibility. And you've got to start taking responsibility for your actions. Or what are we doing here? What are we doing? We're just going to keep taking Suboxone, Subutex in addition to Opana or methamphetamine or cocaine or morphine, or fentanyl, which is very
Mm.
dangerous. We're going to keep mixing these poly substances and continue to threaten your life, because that's basically what it is. And when I talk to them from that standpoint, I sometimes get really good results and I sometimes get yelled at, but I'm here for both of them. Uh, that is a challenging population, because you have to have empathy and compassion while you're still trying to make sure that you are being an appropriate provider. This is a very
Mm.
highly regulated medication.
Mhm.
And this diagnosis can also cause a lot of overdosing and death. So
Right.
this is a very serious diagnosis and very serious management, which is why we require them to also do counseling. If they can't afford counseling, Daymark is somewhere that can offer them discounted counseling or free, as
Mhm.
well as I allow my patients to attend an NA or AA group several times a week and bring me proof from their sponsor, because that's also a good way of making sure they're doing something to facilitate their medication. As we mentioned earlier, the medicine is not even half the job.
Right.
It's
Right.
what the patient puts into it and what we facilitate that patient putting into it that really gets success. I've had, did you want me to speak about that patient now or a little later?
Yeah, let's talk a little bit about the successes. I mentioned to you earlier that we did an interview with a peer support, and she shared some similar stories from the perspective of a peer support where there was a success story, or I think she's had several of them actually similar to the one that you're going to share. So absolutely, go right ahead. We can dive right into that.
Absolutely. This is one success story. Not saying this is, all that I've encountered, but this one for me is special because I've known this patient since 2014. I want to say, because remember I said there was a time where I was in psychiatry, left and came back. But when I came back, she was there. When I came back in 2016. So then we restarted our provider-patient relationship. She, to be honest, has been one of the most compliant patients I have, though, which is very challenging in this field of addiction management. Most of the patients that get to this stable place have been in management for a couple years. I've got some patients.
She started using or participating in MAT at what point? Was she
2016.
16, so she was on buprenorphine in some form from 2016 and
Up until about 6 months ago.
okay, all right.
Prior to that, she was being managed for other psychiatric diagnoses, because a lot of patients are not. So when we speak of opiate addiction, I don't want everybody to assume that means that they were on some sort of illicit opiate medication. Some patients have been on pain management for a long time.
Absolutely.
And in 2014, I remember the diagnosis of opiate addiction coming out, or opiate, not coming out, but being added to all of the patients' charts that had been taking pain medications for a year or more.
So it's called opioid use disorder.
Yes, opioid use disorder.
In some way, shape, or form, either it's from the street or from the dentist who overprescribed.
Yes.
I don't want to give dentists a bad rap, but any provider who is prescribing and then the patient continues to use.
Yes. Yes. And some of them, some of the population has just built a tolerance to the medication, although they still may be on the medication, but that's opiate use disorder, because in the event that they stop that medication, their body shows physical signs. Sure. It shows those withdrawal symptoms. That's how you know that that person has, that diagnosis. That's one of the ways I use cows, which is one of my tools that I use when doing an intake with an opiate use disorder patient, is that. And that includes their physical symptoms. They have to come in withdrawal in order for me to say, you need this medicine, because if it doesn't cause withdrawals, you don't need it.
Right. So that's when the induction happens.
Yes. Yes, absolutely. Some providers do the where they view them taking that medication and have them come back in about an hour, or they sit there for an hour, 30 minutes, and make sure that there's no adversity to this medication. But this patient in particular started, and she was not as together, I guess, as you would say, in her career, her family, and her social relationships as she is now. I can now look at her and say, you're now like a business owner. Your children have been well taken care of, like watched her life completely change. And then she slowly, so she was taking Suboxone films. Once again, Subutex should not be offered unless there is an allergic reaction to Suboxone. So she was taking Suboxone films, and her therapist so therapists play a huge role in this. Sure. They play a huge role in the sobriety of the patient, as well as when it's time for them to titrate down. To taper down. Titrate up, taper down. So and I always encourage that. Do not depend on Tiff to help you make sure that you were mentally sound because that would cause mood changes during this time of taper. You need to have a counselor, your therapist, someone that hopefully has known you for a while that can help facilitate this.
Right.
Because depending on how much I drop a patient, their body will show physical signs as well. So we've got the therapist. She, on her own, talked with her counselor, and they all decided the way that they were going to come off of this medication. I would see her once every 28 days because she had gotten to a point where she was stable enough to be a 28-day follow-up. Her urines every month had been consistent for years. And she mentioned it one day. She's like, I don't feel like I need that much, of a dosage any longer. So I said, well, let's start with just taking it down, maybe just two milligrams, and see how you do with that. And then you definitely speak to Ms. Collette about how you're going to manage this in this process. Yes. Her therapist, who she's very close with. She still to this day sees Ms. Collette. I encourage it. So I would talk to her every month, and every month she would come and request for me to go down. And after about 6 months, she just said, why don't we just cut the whole dosage in half? Okay.
Wow.
You sure you're ready for that? And let's just make sure you don't have any physical withdrawal symptoms, and we can do this. I'm never going to hinder a patient from wanting to, because the goal of this management, MAT, is not to remain on the opiate agonist. It is to eventually get yourself down to a point where you no longer have to take it, and you get your pain managed a different way, if that's what the dual diagnosis is for that particular patient.
Yeah, there's a little bit of controversy about that. So
Yeah.
let's just put that out there. But like you, I believe if patients want to at least try to move in that direction, we shouldn't, as providers, hinder that.
Mm-hmm. I wouldn't. Yeah, but yeah, you are right. There's some controversy in encouraging it, and just tapering a patient down after a certain time frame
Right.
has been,
Right.
that's another discussion. But
Right. Right.
I don't tend to push them to do that, because some patients, like I said, are also treating pain. Suboxone doesn't treat pain as much as an opiate does, but it does help.
Right.
So she tapered down, got to half, and then a few months later now, I was still seeing her. We were still talking. She was doing her therapy twice a month. And although there were things that happen in life around all of us have things that occur, she was still standing strong. Came into the office one day. Of course, it was on the computer because it was COVID, but I was able to speak to her this way. And she's like, I don't even take it anymore. Here's the remainder of my script from the month. What?
So how long has she been completely off of MAT?
Let me think. April, January, February, March. So 4 months,
4 months.
almost 5 months. And I still see her. And
That's
she
a
still
success
comes
story.
monthly.
Yeah, that's a success story. Life still stable for her.
Still stable. Her children do well in school. She is your typical mom, working mom. Her relationship with her husband and her family members has become more solid over all of these years.
Mhm.
It wasn't something that happened overnight, and I try to explain
Right.
that to patients. With
Sure.
success,
Absolutely.
you've got to give it when you're ready.
Right.
If you're ready to taper, and when you're ready to taper, that is something that you have got to make that decision for, because
Yeah.
it's going to take some work and some commitment.
That's pretty amazing.